Today's episode of the StallSide Podcast was brought to you by Root and Riddle Veterinary Pharmacy.
Bart, how are you going today?
I'm great. Good afternoon, Peter. How are you?
I'm great. Yeah, we've got a very interesting guest on the show today that we're really glad has come back to us.
Yes, I think people are going to love her, Dr. Ali Broyles, who is kind of grown up with us, went away, did some things, worked for us in Saratoga, and I'm sure she'll tell her story, but a great personality. She's an excellent veterinarian, excellent surgeon, and thrilled she's back with us.
Yeah, I'm really interested in her take on upper airway surgery. I mean, she's done a lot of like racing quarter horse work and very skilled in thoroughbreds, and so it'd be interesting just to hear about any sort of contrast and similarities between sprinters, essentially, right? Drag racers of the horse world, and actually thoroughbreds that run over a little bit of a longer distance. But yeah, I'm really interested to see what she is going to say. Extremely skilled surgeon and right out with the latest.
Right on. She's a lot of fun, and like I said, thrilled she's back. So let's get her in.
Yeah, absolutely. So on StallSide this week, we have Dr. Ali Broyles, who's going to talk to us about upper airway surgery in the horse. Dr. Broyles, welcome to StallSide.
Thank you.
Thanks for being with us. It's great to have you back in Lexington, and thanks for coming on the show with us today.
Yeah, of course. Happy to be here.
Yeah, so Ali, tell us a little bit about yourself.
Okay, so I grew up in Tennessee, Murfreesboro, which is in the middle part of the state. My dad has always had horses and cattle, so grew up with horses and cows. And I honestly can't remember why or when I wanted to be a vet, but I just always wanted to be a vet. And initially, I wanted to be a large animal vet, but then later, probably in high school, decided I wanted to do just equine. So went to college in Murfreesboro. My dad was a college professor, and I went to the college that he worked at. And then after undergrad, I moved to Texas, and I worked at the 4-6s Ranch in West Texas for a year and a half. And so I became a Texas resident there. And then applied to vet school at A&M and got into A&M, went there. And then my husband is also a veterinarian, and he was in my class. And so we got married after my internship here. But yeah, so after vet school, did my internship here at Root and Riddle, and then went back to Texas and worked with Brandon, my husband, for a few years. And then also worked part-time for a racetrack practice that did mostly quarter horses, and went to racetracks in Texas, Oklahoma, Iowa, and Florida, kind of part-time. And then came back in 2014 and did my residency here. And then after my residency, worked at the Saratoga practice for a little while, and then went back to Texas again as a associate surgeon at a practice near Fort Worth.
So quarter horse racing, tell us about that.
So quarter horse racing, obviously they race a much shorter distance. And believe it or not, the size of the quarter horse is about similar to the thoroughbreds. They are pretty big.
Mm-hmm.
Some people think that they're going to be a lot smaller, but honestly their body type is similar to a thoroughbred, just maybe a little bit more muscular. But I would say in Texas, Oklahoma, New Mexico, the quarter horse racing is quite a bit more popular, in the western states. But it seems like they have a race meet at the Red Mile now.
Have you been out there, Pete?
No, I haven't been out there.
Oh,
yeah.
Quarter horse racing is a blast.
Yeah.
It's a lot of fun. It is just, it is 21 seconds of chaos.
Yeah.
It sounds like the drag racing of the horse industry, doesn't it, really?
Well, that picture right back there.
Yeah.
That's chariot racing. That's two quarter horses hooked
Oh, yeah.
together,
Yeah.
going 440, and that's actually a picture of me beating my dad. That's why that sits there. But that's I grew up quarter horse racing too.
Yeah.
Oh, okay.
What a hoot!
Yeah, but that's the fascinating thing about quarter horses, right? Is that there's so many different conformations, and they've been tailored to the career that people have. Like you've got cutting horses, you've got roping horses, you've got holder horses, you've got racing quarter horses, right? And you sort of think that that's just a triumph for selective breeding, isn't it? Really, is that they've managed to have so many different sort of applications for the one style. But we're here to talk about upper airway surgery today. So give us your take on upper airway surgery. What's your focus? What do you think it can do for the horse? And what are the current developments that you see coming down the line that are going to advance the science for everybody?
Okay, so probably the two I'll just talk about the two most common surgeries that we do, or for the two most common problems, I would say. So recurrent laryngeal neuropathy is probably the most common reason a horse would come in for upper airway surgery, and that is just partial paralysis or complete paralysis of the left arytenoid most commonly, or the flapper would be kind of the layman's term. And so typically the horses that present, and you can see it in all types of horses, obviously, but we see most commonly in thoroughbreds here. And in Texas, we saw it in quarter horse race horses as well. Not quite as common as it is in thoroughbreds, but we did see it occasionally. And they present usually for poor performance, probably making a noise at exercise. And the horse has most of the time been scoped by the referring veterinarian on the racetrack or the farm. And now it seems like they're sending them in more earlier in the disease process. Previously, people would sometimes wait until their arytenoid was completely paralyzed to send them in for surgery. But now we kind of know that actually it's better if you go ahead and do the surgery before they're completely paralyzed. So that's been a change in the thought process in the past few years.
What's the advantage of sending them in earlier? Is there like less downstream pathology, and if so, what is that pathology?
Yeah, so actually my resident, or I actually did this paper, started collecting the data when I was a resident, and then published it a few years after my residency. And we looked at, I think there was like 600 tiebacks that we looked at and kind of compared, ones that are partially paralyzed and ones that are completely paralyzed, and at the time of surgery, and then looked at, how long it took for them to come back to racing, likelihood of return to racing, and then their earnings. And the reason we did that paper is because a lot of referring veterinarians were waiting to send the horse until it was completely paralyzed, thinking that if the arytenoid still had movement, it might cycle the prosthesis, and so they would have a poorer prognosis post-operatively if they had some movement. And we didn't think that was truly the case, so kind of wanted to prove that. And in the paper, we looked at grade 3 ones, which is still have a significant amount of movement, but they can't hold their abduction fully. And then 3 2s and 3 3s, which is a little bit of movement, not completely paralyzed. And then grade 4s are complete paralysis. And so all of the grade 3s actually ended up taking less time to return to racing, and were more likely to race as well. And we don't know why that is. We honestly thought it would be the same in 3s versus 4s, but potentially maybe it's a psychological thing for the horse, that if they were running with complete paralysis, maybe they remember that. I don't know. So that was our kind of only hypothesis of why there would be a difference there.
Right.
So would you find that true? These are horses that were racing, right? What about in our yearling population, if you're finding those 3s and 4s? Because traditionally we've said just go ahead and break the horse, and then next spring we'll see where they're at.
Okay, but before doing the tieback. I think we're still recommending to do that, as far as to break the horse and then do it. And the reason for that is because at a yearling age or young 2-year-old, their cartilage isn't as strong as later on. So I think we have more failures on yearling horses than we do on adult horses, just because the cartilage isn't fully matured. So that would be the reason why. Okay. Not necessarily waiting for paralysis.
So what are some of the complications of the tieback surgery?
So probably the most common complications would be aspiration. So if you have them tied back too much, that they can't protect the airway, or failure of the tieback. I mean, you get a little bit of, it's pretty normal to get a significant amount of relaxation post-operatively. We do know that about 6 weeks is the cutoff for, like, if you go scope the horse after surgery at 6 weeks, the amount of abduction you have there is probably what you're going to have later on. So we still tell people, the success rate is about 65 to 70%. But yeah, failure is a complication, aspiration pneumonia, incisional infection. Those are probably the biggest complications.
Okay. And so this is a solution, but it's not, they're not as good as if you had a functional airway,
Yeah.
correct? So what's the prognosis for a horse that has a tieback? How do they perform compared to everybody else?
You're probably 70% at return to racing at their previous level.
At their previous level.
Yeah.
Okay.
But,
So,
I mean, let's face it, it's a salvage procedure, right? Because you've got nothing.
yeah,
right?
yeah, exactly. Right. If you don't do the tieback, then a retinoidectomy is another option, but in racehorses, it's not a good option. Those horses don't usually do well because there is still tissue there that will obstruct the airway. There is a new procedure where we are trying to, it's called a renervation, where we're trying to, restore the normal function, but we just haven't had good success in racehorses. It might be a better procedure for a different type of performance horse, but for racehorses, it's just not able to hold the arytenoid out during maximal exercise.
Gotcha. So this is actually very timely because I had a client yesterday. They've got a yearling that's completely paralyzed on the right side. And they go, so they asked me the question, which I'm going to ask to you, if we choose not to do the surgery, what is this horse capable of? Obviously being a racehorse is off the table. But what are those horses capable of doing if you don't do a surgery?
Well, so one thing to consider in a horse with right-sided paralysis is to make sure it is recurrent laryngeal neuropathy and not laryngeal dysplasia. Because a lot of laryngeal dysplasias will look like a paralyzed arytenoid, and actually the tieback will not help those horses just because their anatomy is abnormal. So a laryngeal ultrasound would be the next step to figuring that out. Yeah. But in horses with recurrent laryngeal neuropathy, if you don't do the surgery, the tieback procedure, if it is a performance horse, that is a low-level performance horse, that the people are just concerned about the horse making noise and it's not actually affecting its ability to breathe, then you can just do a vocal chordectomy where we use the laser and remove the vocal cord in addition to the ventricle, and that will help with the noise production and maybe give them a little bit more of an airway, but it's not good enough for a racehorse.
Yeah. So just because they're making noise doesn't mean that the horses are distressed.
Yeah, exactly. And that's, in Texas, we saw other types of breeds frequently that not racehorses, that a lot of times the complaint was the horse is making a noise at exercise. And so you always have to ask them, because there are complications associated with doing the tieback. So you don't want to jump to a tieback if the horse doesn't need it. So I try and extract that information out of the owner. Are you just concerned about the noise, or do you think that the horse is having a hard time doing its job because it can't breathe?
It's interesting. It talked about like laryngeal surgeries for loss of function. You mentioned there was another most common type of surgery and another problem that was sort of most common. Okay,
so dorsal displacement of the soft palate is probably the second most common thing that we see in racehorses and then other breeds of horses as well. This is a little bit more difficult to diagnose on standing endoscopy. They won't always do it. So a lot of times we're diagnosing it with dynamic endoscopy and watching their airway at exercise. Interestingly, recurrent laryngeal neuropathy is an inspiratory disease, and displacement of the soft palate is an expiratory disease. So sometimes if the people are talking to you about the sound the horse is making or what the horse does when it makes that sound and can't breathe, you can kind of decipher which one it might be. So for displacement of the soft palate, a lot of times they'll stretch their neck out or kind of open mouth breathe, and they make more of a gurgling sound because they're having a difficulty getting air out. Instead of with recurrent laryngeal neuropathy, those horses are having trouble getting air in, and they often make a more of the classic roaring sound.
So, that's interesting about the position of the head, because that's something that they're just trying to like straighten things out, right? So that's interesting. Just by talking to somebody, you can get a pretty good idea what's going on.
Yeah, and so even in the standing exams, a lot of those horses displace, and they're displaced forever. But that has nothing to do with performance. That's not necessarily an indicator that those horses are going to displace when they race, is it?
Correct. Yeah.
Yeah, so as far as endoscopy goes, you're talking about like overground dynamic. Treadmills used to be pretty big, right? And so people have gone away from treadmills now. So why is that, that people have left treadmills behind and have gone for the overground?
Yeah, so the nice thing about the overground is you can more easily replicate, the horse's environment of where they're actually having the upper respiratory obstruction. So they can be in their normal tack in the, on the racetrack, have the rider in place, and all those things can affect what you see on the exam. So especially with like dorsal displacement of the soft palate, a lot of times head position will affect that. So in maybe not even a racehorse, but a dressage horse or saddlebred or something like that, when their neck is flexed, they're going to have different obstruction than when their neck is straight.
Okay. And so surgically, what can you do about that dorsal displacement of the soft palate? Obviously that's a major issue. So how can you surgically approach this? More than one approach, some better than others?
Yeah. So there's multiple approaches. Probably the gold standard would be a laryngeal tie forward. And that procedure, unlike the tie back, has a lower complication rate. Probably the biggest complication with that is that, it doesn't work, or they have some incisional seromas, but you don't have the higher risk of, significant complications like aspiration pneumonia. The procedure below that, maybe that is more frequently performed, but maybe is not the gold standard, is a myectomy, which we do the myectomy during the tie forward procedure anyway. But a lot of times we'll get horses that they've had a myectomy. You can do those standing on the racetrack. Racetrack veterinarians will do them in the field. And I did them in the field on quarter horse racehorses. But if that doesn't work, sometimes they'll send them for the tie forward later on.
Can you give us just a brief 10,000-foot overview of what those two surgeries are, the myectomy and the tie forward?
Yeah, so the myectomy is where you cut the muscle that kind of attaches to the thyroid cartilage. And so that muscle is called the sternothyroideus. And we think that maybe when you cut that muscle, that it's not pulling the larynx back, so that it's less likely to displace. So, and then when you do the tie forward, what you're doing is you're basically pulling the larynx forward and up over the soft palate. And so you're kind of holding it in place there so that the position of the larynx versus the soft palate is different, so that they're, to decrease the rate that they do displace.
Does that alter the horse's ability to swallow or the way it swallows?
No, usually not. I will say sometimes post-operatively, like in the first couple days, the horses have some discomfort, like putting their head all the way down. You can tell it's a little uncomfortable for them to do that, to stretch their neck out. But then that seems to go away, in the first few days or so. But no swallowing. I've never had a horse have any issues swallowing with that procedure.
Okay, that's interesting, because you think altering the architecture like that, they just probably quickly learn their way around it.
Yeah.
And you mentioned some new techniques that are coming down the line. You mentioned about the reinnervation technique for the laryngeal hemiplegia. Any other new techniques coming along, or diagnostics for upper airway dysfunction?
No, right now, we routinely we're doing dynamic endoscopy, laryngeal ultrasound, and obviously standing and endoscopy. Typically, here at the hospital, if any horse that's getting standing endoscopy is likely going to get a laryngeal ultrasound, just because it gives us good information about the architecture of the larynx, laryngeal cartilages, and then just the more you do it, I feel like the more information we get from the laryngeal ultrasound too. But yeah, not every horse gets a dynamic endoscopy if it's pretty convincing on standing endoscopy and laryngeal ultrasound.
You mentioned earlier about laryngeal dysplasia, and I was going to ask you about that at the time. I mean, you're talking about right-sided problems and making sure that wasn't the case. How do these horses usually present? Do they present any differently, and this is just like a differential that you work out, or is there something unique about these horses? And how does this come about? You know, what's missing, what's malformed?
Yeah, so for laryngeal dysplasia, a lot of times they just present, you know, as yearlings because they've been born with this deformity, and it's diagnosed when you guys are scoping them for sale. Or maybe when they go to be broke, they make a noise like a horse with a paralyzed arytenoid, and you scope them and they have what looks like right-sided recurrent laryngeal neuropathy. But it's just much more common for them to have a left recurrent laryngeal neuropathy versus a right. And most of the time, the right side, what appears to be a right-sided paralysis is more likely laryngeal dysplasia. And how this occurs is just a malformation. It's a fourth brachial arch defect is the term. And what happens is the cartilages on the right side are just not, they're not in the correct position. So there's a gap between the thyroid cartilage and the cricoid cartilage that's not normally there. And that's why doing a tie back on those horses just doesn't work because the anatomy is not normal.
Excellent.
That's pretty interesting stuff, yeah. And so we get the occasional neonate in here that we've actually found some problems because, yeah, they're like dysphagic, you know, a little bit of milk going in, and you actually scope them and your heart sinks a little bit, right? Because you just look at that and says something not right about that. So then they call somebody clever, like one of the surgeons, and they come and have a look at it, and they sort of says, yeah, you know, it's a malformation, and you just can't do anything for people. And but these foals are like so compromised that they're aspirating.
Right. Yeah. And it seems to be varying degrees of laryngeal dysplasia. Some are more, you know, malformed than others. So.
Yeah, and I probably just see the worst ones because that's the ones that get into trouble early. Yeah. And, you know, the worse they are, the earlier we find them. And then you get something, as you say, around yearling age when everybody has a lot of hope for the horse, and then something like this turns up, which is pretty unfortunate. Yeah, so any other upper airway surgeries that you'd like to talk about today? You've talked about, you know, as I say, DDSP, you've talked about laryngeal hemiplegia. Is there anything else that is becoming more of a problem, more prominent? People are realizing it's more performance limiting that can be addressed surgically?
I guess the other thing we see probably most commonly is epiglottic entrapment. And, you know, sometimes that's confused with displacement of the soft palate. But actually what an epiglottic entrapment is where there is a band of tissue, it's the subepiglottic tissue that flips up and traps the epiglottis. And then the surgical correction for that is to transect that band of tissue. And it can either be done with the laser standing or under anesthesia through the oral cavity with a hook blade or some scissors or a combination of both. It's kind of a tricky procedure as far as a lot of times that subepiglottic tissue that you transect will become inflamed, and so you do have to really watch those closely after surgery because one, they can re-entrap, or two, that tissue will get inflamed and cause some problems later on. So it's not always a straightforward procedure, even though it sounds simple.
Yeah. Because of this tissue in the wrong place, is there any like ulcerations or anything that actually occur, and how do you sort of recognize those?
Yeah, so preoperatively, you can kind of decide maybe or have an idea of which ones are going to have more trouble after surgery because they present in varying forms. So sometimes the tissue it must have been very acute and the tissue's not inflamed at all, and those tend to go pretty well. But sometimes it may be a few days or even a week or two that the horse has been entrapped, so that tissue is more thickened, and yes, it can be ulcerated as well. And then if it's been entrapped for a really long time, you can get some malformation of the epiglottic cartilage, and that is difficult to resolve once you get the malformation of the cartilage itself.
How does the cartilage change with that condition? Like it's usually like fairly pointy and triangular and symmetrical. So what do you see in that situation?
Yeah, so a lot of times it'll be blunted or even I've had a couple that were kind of just kind of zigzagged at the end, like it's been, kind of smashed up against that tissue. And once the cartilage, there's not much you can do to restore that normal structure of the cartilage.
Anything locally medically you do with these? Because you mentioned ulcerations and that sort of excessive tissue that can develop. Besides the surgical part, what does any sort of like topical medical or systemic medical things and convalescent periods for those horses? How do you manage those?
Yeah, so sometimes if they're really, really swollen, you might go ahead and start them on medications even before, and maybe wait 24 hours to do the surgery. So you might start them on some anti-inflammatories systemically and with throat spray or nebulizing, and then also antibiotics because there's usually some infectious component as well. And then post-operatively, we monitor them very closely. While they're in the hospital, we'll scope them every day. And then when we send them home, we try and look at them once a week or once every other week, depending on how they're progressing. And they're usually sent home on throat spray or, nebulizing if they have a nebulizer, oral antibiotics, Banamine, and then also some steroids like prednisolone or even dexamethasone.
I found the nebulizer to be very helpful with a lot of those cases.
Right. You're nebulizing like antibacterials or corticosteroids or silver.
Even just the silver spray is is helpful.
It seems like,
but yes, you can put a lot of stuff in the nebulizer.
Yeah, you can. Yeah. But that just it's just like really not just surgery and done. I mean, this is like a real comprehensive approach to these horses because it's potential to be career ending if it's not.
Yes,
right?
For sure. Yeah.
Well, one thing I found, and this is a little bit of a jump, when a few years back we had a large farm that had a strangles issue, and so when we got everything pretty well cleared up, it kept recurring, and so we had to find the culprit, and so we did endoscopy on the guttural pouches of about 200 mares. The most striking thing that I found though was how much pathology some of these older horses are living with, so we figured out, that's why this horse can never gain weight because her retinoids are just massive and draining, and so we actually did surgery on a couple of those horses. So I think it's probably a good thing for veterinarians and owners to remember, especially with older horses, when you have a workup for a weight loss, to make sure you look at their upper airway, because a lot of stuff can happen in these older horses. Yeah,
and sometimes it's an incidental finding. You look there and the airway's almost like closed over, or they acutely close over.
Yes.
And you're looking at it and sort of thinking, this has been going on for a long time, and they'll be, she's just breathing a little bit funny, or as you say, you had trouble putting weight on her, she stood with her neck sort of stuck out, and everybody wondered why. It's because their laryngeal cartilages are on fire and they're losing their airway. Interesting stuff.
Yeah.
Yeah. So, well, thank you for coming in and seeing us today. It's been a fascinating tour of the upper airway of the horse and the surgeries that are actually possible to fix things up. And you've had a very interesting career, like racing quarter horses. You've got me convinced I have to go and have a look.
We need to go. We need to go. When they're here at the Red Mile, we got to go.
Yeah, we've got to go because, I've sort of seen video, they start here and they sprint. It's sort of like, they're the Usain Bolt of the horse world. They just drag race and that's it and they're gone. And as you say, it's pretty quick, and the thoroughbreds, we just watch them go around the track and potentially have different problems, but I mean this airway sounds like it's pretty common between the two breeds and within disciplines within the breed.
So in quarter horse racehorses, one thing about them is they don't they can get by a little bit better with these airway problems because they don't have to run as far. So I do feel like we had a better success rate with tiebacks in those horses, because even if you help them a little bit, they didn't have to go very far. So
how many times did they breathe in that 21
Yeah, exactly.
Right? Because, I mean, it's a sprint, right? Yeah. So the thoroughbred is like with the stride, breathe, right? With those quarter horses are so fast, they probably don't do that.
Yeah.
Something to think about. Yeah.
Okay.
Well, excellent. Well, again, thank you for coming on StallSide. This has been a fascinating talk, and I'm much more knowledgeable, I think.
Me too. Yeah, hopefully our listeners are as well. It was a good conversation.
Yeah. So that's StallSide for this week. We've been talking to Dr. Ali Broyles here at Root and Riddle about upper airway surgery. See you next time.